Before starting of the topic, previously we covered mechanism of pain and gate control theory. Then comes to the classification of pain. I am Paramita Chatterjee, Masters in Critical Care Nursing. So welcome sisters in my topic, classification of pain. Pain can be categorized in several ways. Most commonly, pain is categorized as nociceptive or neuropathic based on underlying pathology. Another useful scheme is to classify pain as acute or chronic. First, nociceptive pain. Nociceptive pain is caused by damage to somatic or visceral tissue. Nociceptive pain means special nerve endings which is situated in the damaged tissue, where the tissue is damaged, called nociceptors, and nociceptors send pain signals to the central nervous system from the damaged tissue to the central nervous system. This is nociceptive pain. Nociceptive pain also categorized in somatic pain and visceral pain. So nociceptive pain is caused by damage to somatic or visceral tissue. Somatic pain, what is somatic pain? Somatic pain is the type of pain you feel in your skin, muscles, joint and bones. It can feel like aching or cramping. Some people describe the somatic pain as sharp pain. When you will experience the somatic pain? If you cut your skin, stretch a muscle too far, exercise for a long period of time, or fall down onto the ground or hurt yourself, this time you will feel the somatic pain. The example of somatic pain are chemical burns, infection, joint dislocation, bone fracture, running into a blunt object can lead to painful bruises. These are all the example of somatic pain. Somatic pain usually is usually isolated to a particular part of the body. Particular part of the body, it is isolated, and it is often made worse with some movement. It is a nociceptive pain which is caused by an injury or inflammation procedure. This is the somatic pain. And what is visceral pain? Visceral pain occurs when pain receptors in the pelvis, abdomen, chest or intestines are activated. We experience the visceral pain when our internal organ or tissue is damaged. This time we felt visceral pain. This is somatic pain picture. This is previously I said that this is localized and a particular part of the body is isolated for somatic pain, and the type of pain is very sharp. This is somatic pain, picture of somatic pain, and this is visceral pain, picture of visceral pain. Visceral pain is usually nociceptive, but it arises from the internal organs. The nerves that detect the somatic pain are located in the deep tissue or organ. The example of visceral pain are stomach cancer, prostate damage, menstrual pain, constipation, infection in the digestive system, and damage to the abdominal wall, injury to the internal organs such as gallbladder, intestine, bladder, kidney. These are all example of visceral pain. So you can differentiate the visceral pain and the somatic pain. First, nociceptive pain. Nociceptive pains are divided into the somatic pain and the visceral pain. Visceral pain is localized pain, and it also a sharp pain, and this pain also very painful, and it's due to the chemical burns, infection, joint dislocation, bone fracture. And visceral pain are vague, is not localized properly, not well understood or clearly defined, or it often feels like deep squeeze pressure or aching. The pain characteristics is deep squeeze and pressure or aching. These are characteristics of visceral pain. And another type of pain is referred pain. Referred pain, what is referred pain? When you have an injury in one area of your body but feel the pain somewhere else. You have an injury in one area of the body but feel the pain somewhere else. Example are cardiac pain, anginal pain. You have an injury in the cardiac muscle and you feel the pain in the left arm. So why this happens? Because all the nerves in your body are part of a huge connected network. Somatic pain, visceral pain and the referred pain. Then comes to the neuropathic pain. Neuropathic pain is caused by damage to peripheral nerves or structures in the central nervous system. Neuropathic pain is caused by damage to the peripheral nerves or structures in the central nervous system. When neuropathic pain is commonly associated with diabetic neuropathy and other neuropathic pain syndrome. Approximately 8% of the general population has pain with neuropathic characteristics, typically described as numbing, hot, burning, shooting, stabbing, sharp or electric shock like neuropathic pain. So, neuropathic pain is the nerve pain that can happen if your nervous system malfunctions, gets damaged. You can feel pain from any of the various levels of your nervous system. Peripheral nervous system, central nervous system. About 30% of the neuropathy cases occurs due to the diabetes, and hundreds of other diseases, that is HIV, AIDS, alcohol use disorder, tumors, toxins, neurologic disease, multiple sclerosis. So, whenever our peripheral nerves or structure in the central nervous system are get affected, then neuropathic pain is occurred. So, this is the neuropathic pain. Then comes to the acute pain. Acute pain or chronic pain. Acute pain or chronic pain differ in their cause, course, manifestation and treatment. Example of acute pain include post-operative pain, labor pain, pain for trauma, that is laceration, fracture, sprains, pain from infection, cystitis, pain from acute ischemia. For acute pain, treatment include analgesics from symptom control and treatment of the underlying cause. So acute pain is frequently distinguished by its abrupt onset and brief duration. It frequently occurs as a direct result of tissue damage or injury. Acute pain is a defensive mechanism to alert the body's possible danger. First alarm system is acute pain. Depending on the underlying reason, acute pain may appear in various ways such as SART, stabbing, throbbing, aching feeling. But acute pain usually has a first onset and is localized to a particular part of the body. Such examples are, if you stub your toe, you will feel the severe pain only in that toe, not other area. So, this is acute pain. And another important characteristics, any pain that lasts less than 3 months, this is acute pain. Any pain that lasts less than 3 months, this is acute pain. Then chronic pain. Chronic pain or persistent pain lasts for longer periods, often defined as longer than 3 months or past the time when an expected acute pain or acute injury should subside. So chronic pain is a pain that is ongoing and usually lasts longer than 3 months. This type of pain can continue even after the injury or illness that is caused, it has healed or gone away. Pain signals remain active in the nervous system for weeks, months and years. Some people suffer chronic pain even when there is no past injury or apparent body damage. So chronic pain is linked to those conditions. These are headache, arthritis, cancer, nerve pain, fibromyalgia. It can significantly impact a person's quality of life, leading to physical limitations and emotional distress and social isolation. So acute pain and chronic pain are completely different from one another. This is the picture of chronic pain. Then numeric rating scale. This is the pain assessment scale. Numeric rating scale, the picture itself says that it is most often presented as a horizontal 0 to 10 point scale with word anchors of no pain at one end of the scale, moderate pain in the middle of the scale, and worst possible pain at the end of the scale. It may also be put on a vertical axis, which may be helpful for patients who read from right to left. This is numeric rating scale. Numeric rating scale, it takes less than a minute to administer and score. This is the advantage. The numeric rating scale allows it to be used internationally without translation or difficulties. It can be administered verbally in a written form. And cons disadvantage, it only evaluates one aspect of pain intensity. It does not factor in post-pain experiences. This is the limitation of this scale, numeric rating scale. Then Ohm-Baker faces pain rating scale. 0 no heart, 2 hearts little bit, 4 hurts little more, 6 hurts even more, 8 hurts whole lot, 10 hurts worst. Ong-Becker Faces Pain Rating Scale. The Faces scale consists of 6 cartoon faces with word descriptors, ranging from a smiling face on the left for no pain or hurt to a frowning, tearful face on the right for worst pain or hurt. Patients are asked to choose the face that best reflects their pain. The faces are most commonly numbered using 0, 2, 4, 6, 8, 10 matrix. Although 0 to 5 can also be used, patients are asked to choose the face that best describes their pain. The Faces scale is used in adults and children as young as 3 years. Then Faces pain scale revised. 0 no pain and 10 very much pain. Faces pain scale revised has 6 faces to make it consistent with other scales using 0 to 10 matrix. The faces range from a neutral facial expression to one of the intense pains are numbered 0 to 4, 6, 8 or 10. As with the Ong-Becker Faces scale, the patients are asked to choose the face that best reflects their pain. Faces scale have been shown to be reliable and valid measures in children as young as 3 years of age. However, the ability to optimally quantify pain is not acquired until approximately 8 years of age. Then verbal descriptor scale. First no pain, then mild pain, then moderate pain, then severe pain, then very severe pain, then worst possible pain. Verbal descriptor scale, a VDS uses different words or phrases to describe the intensity of pain, such as no pain, mild pain, moderate pain, severe pain, very severe pain, and worst possible pain. The patient is asked to select the phrase that best describes pain intensity. Then pharmacological management. First, selected non-opioid analgesic. Selected non-opioid analgesics consists of non-salicylates and salicylate and non-steroidal anti-inflammatory drugs. Non-salicylate acetaminophen, salicylate aspirin. Non-steroidal anti-inflammatory drugs are ibuprofen, naproxen, ketorolac, diclofenac K and celecoxib. So, what happened in non-opioid analgesic? Arachidonic acid is oxidized by two different pathways. One is lipoxygenase and another one is cyclooxygenase. Here we concentrate about the cyclooxygenase. The cyclooxygenase pathway leads to two forms of the enzyme, cyclooxygenase 1 and cyclooxygenase 2. Cyclooxygenase 1 is known as constitutive, always present, and cyclooxygenase 2 is known as inducible. Its expression varies markedly depending on the stimulus. Non-steroidal anti-inflammatory drugs differ in their actions, with some having more effects on COX-1 and others more on COX-2. So, what happened? when the all non-steroidal anti-inflammatory drugs inhibit cyclooxygenase, the enzyme that converts arachidonic acid into prostaglandin and release related compounds. The enzyme has two forms, COX-1 and COX-2. So COX-2 is produced mainly at the site of tissue injury where it mediates inflammation. The inhibition of COX-1 causes many of the untoward effects of NSAID, such as impairment of renal function, bleeding tendency, and GI irritation and ulceration. And inhibition of COX-2 is associated with anti-inflammatory effect. The picture itself shows if the COX-2 it inhibits, then anti-inflammatory effects, inflammation and fever not occur, and analgesic effect. And here the hemostasis comes to the bleeding, and GI mucosal protection also comes to the GI bleeding if COX-1 block. So this is the mechanism of NSAIDs. Then some characteristics of non-opioid analgesics. Analgesic selling properties. First one is analgesic selling properties. The dose beyond which there is no additional analgesic effect despite increased doses. The patient obtains no additional pain relief. If you increase your dose, but analgesic effects will be remain as it is as before. There is no effect on analgesic effect if you increase your dose. This is the analgesic selling properties. The non-opioid analgesic do not produce tolerance or physical dependency. Non-opioids are effective for mild to moderate pain. They are often used in conjunction with opioids. These are the properties of non-opioid analgesic. Then opioid analgesic. Morphine, hydromorphone, methadone, levorphanol, fentanyl, oxymorphine and oxycodone. First mode of action of opioids, it inhibits the transmission of nociceptive input from the periphery to the spinal cord. And second one, activate the descending inhibitory pathway that module the transmission in the spinal cord. First inhibit করছে ট্রান্সমিশনটাকে, যেটা কিনা নসিসেপটিভ এরিয়া থেকে স্পাইনাল কর্ড অবধি যাচ্ছে, পেন ট্রান্সমিশনটাকে ইনহিবিট করছে এবং ডিসেন্ডিং যে ইনহিবিটরি পাথওয়েটা তৈরি হয়েছে সেটাকে অ্যাক্টিভেট করছে যাতে মডিউল করা যায় ট্রান্সমিশন অফ দ্য পেন টু দ্য স্পাইনাল কর্ড, কন্ট্রোল করা যায় স্পাইনাল কর্ডের পেন ট্রান্সমিশনটাকে। এটাই হচ্ছে ওপিওয়েডসের মেন কাজ। এবার ওপিওয়েডসের কিছু রিসেপ্টার আছে, সেই রিসেপ্টারের সঙ্গে ওপিওয়েড যদি একসঙ্গে হয় তবেই হচ্ছে ওপিওয়েডস কাজ করতে পারে। যেমন লক অ্যান্ড কি, লক আর দ্য রিসেপ্টার্স, কি আর দ্য ড্রাগ। যে লকে যে কি লাগবে সেই কি যদি সেই লকের সঙ্গেই অ্যাটাচ হয় তবে প্রপার ওপিওয়েড অ্যানালজেসিক এফেক্ট পাওয়া যায়। এখানে রিসেপ্টারগুলো হচ্ছে মু, কাপ্পা অ্যান্ড ডেল্টা। মু কোথায় থাকে? থ্যালামাসে থাকে, গ্রে ম্যাটারে থাকে, ডরসাল হর্নে থাকে মু রিসেপ্টার। কাপ্পা রিসেপ্টার সেরিব্রাল কর্টেক্স, হিপ্পোক্যাম্পাস, ডরসাল হর্ন, মিড ব্রেন অ্যান্ড ডেল্টা অল দ্য এরিয়া প্লাস ট্রাইজেমিনাল নিউক্লিয়াসে প্রেজেন্ট থাকে। Then first, another one is endogenous opioid peptide, which is released by the body when our cerebral cortex perceive pain sensation. Then body released endogenous opioid, that is enkephalins, and endorphins. When and another differentiation is strong agonist opioid, moderate agonist opioid, and mixed agonist opioid. Strong agonist opioid are fentanyl, hydrocodone, methadone, and moderate agonist opioids is codeine, and mixed agonist and antagonist are pentazocine. But here the agonist effects is also seen and antagonist effects is also seen. This is pentazocine. Then another one is naloxone. Naloxone is opioid antagonist, means যখন opioid analgesic এফেক্টটাকে কম করার দরকার পড়ে বা রিসেপ্টর থেকে ওপিওইডটাকে বের করে নিয়ে আসার প্রয়োজন পড়ে, লক থেকে কিটাকে বের করে নিয়ে আসার প্রয়োজন পড়ে, যখন ওপিওয়েডের এফেক্ট অনেক বেশি হয়ে যাচ্ছে তখন আমরা ওপিওয়েড অ্যান্টাগনিস্ট অ্যাপ্লাই করছি, যেটা হচ্ছে ন্যালোক্সন। দেন হোয়াট ইজ দ্য মেকানিজম অফ মরফিন? Morphine first reduce the calcium entry in the presynaptic nerve. So if calcium is inhibited or calcium entry is reduced, then action potential also reduce. If action potential is reduced, then neurotransmitter release also reduce. If neurotransmitter release reduce, then pain perception to the cerebral cortex is also reduced and analgesic effect will be seen. This is the main action of morphine. It reduces the entry of calcium. Due to this reason, action potential inhibited, and if the action potential is inhibited, then neurotransmitter release is also inhibited, and then pain perception also inhibited. It has two main side effects, that is respiratory depression. Why respiratory depression occur in morphine? Because morphine depresses the vasomotor center, so respiratory depression occur, and euphoria, feeling of well-being, and the dependency. These drugs also a side effect, and constipation. These are all side effects of opioid analgesic. Then comes to the other drug of pain management. These are antidepressants, tricyclic antidepressants, SNRI antidepressants, anti-seizure drug, carbamazepine, phenytoin, gabapentin, GABA receptor agonist, baclofen, and alpha-2 adrenergic agonist, which is clonidine, and anesthetics local, which is lidocaine. So, first, antidepressants drug. Tricyclic antidepressants enhance the descending inhibitory system by preventing the cellular reuptake of serotonin and norepinephrine. Tricyclic antidepressant enhance the descending inhibitory system by preventing the cellular reuptake of serotonin and norepinephrine. If prevent the reuptake of serotonin and norepinephrine, then higher levels of serotonin and norepinephrine in the synapse, and higher level of the serotonin and norepinephrine also inhibit the transmission of nociceptive signals into the central nervous system. Antidepressants that selectively inhibit reuptake of serotonin and norepinephrine, this is SNRI, are effective for more neuropathic pain syndrome. Then another one is Anti-seizure drug. Anti-seizure drug affect the peripheral nerves and the central nervous systems in various ways, including sodium channel modulation and also central calcium channel modulation. Then GABA receptor agonist, which is baclofen. Baclofen can interfere with the transmission of nociceptive impulses and is used for muscle spasm and neuropathic pain. This is the mode of action of baclofen. Then alpha-2 adrenergic agonist, which is clonidine, central inhibitory alpha adrenergic receptors. Then anesthetics, local lidocaine. Topical local anesthetic cream applied to the intact skin before venipuncture or lumbar puncture, or 2%, 2.5% lidocaine or 5% lidocaine also used. So this is the anesthetic effect. Apply locally or IV. These are all pharmacological management. In the local anesthetic for acute pain from surgery or trauma, local anesthetics such as administered epidurally by continuous infusion, or topical applications of local anesthetics are used to interrupt transmission of pain signal to the brain. For example, 5% lidocaine patch is recommended as a first line agent for the treatment of several types of neuropathic pain. And in the treatment of chronic severe neuropathic pain that is refractory to other analgesics, oral therapy with mexiletine may be tried. Systematic lidocaine administered in the form of an IV infusion is also sometimes used for neuropathic and post-operative visceral pain. Then non-drug therapies for pain. Non-pharmacological management. Here first one is the massage. Massage is useful for acute or chronic pain. For acute or chronic pain, massage is very useful. Many different massage technique exist, including moving the hands or fingers over the skin slowly or briskly with long strokes, or in circles, superficial massage, applying firm pressure. All those massages activate the A beta fibers, which reactivates the inhibitory descending neuron, which stop the transmission of nociceptive stimulus from the tissue injury to the central nervous system, which is gate control theory. It closes the gate. When you rub or massage the body, the inhibitory neuron get activated and it closes the gate. This is the mainly mode of action of non-pharmacological pain management. Exercise also it activates the descending pathway and inhibit the pain transmission. So one jokes are there, যখন অ্যাথলিটরা খেলে তখন তারা তাদের পায়ের ব্যথা বুঝতে পারে না, যখন খেলাটা বন্ধ হয়ে যায় তখন তারা তাদের শরীরের যন্ত্রণাটা অনুভব করে, কারণ এই টাইমে যখন তারা এক্সারসাইজ করছে বা খেলছে এই সময়টায় হচ্ছে ডিসেন্ডিং পাথওয়ে অ্যাক্টিভেট হয় এবং গেটটা ক্লোজড হয়ে যায়, তাই পেন ট্রান্সমিশন হয় না। দেন ট্রান্সকিউটেনিয়াস ইলেকট্রিক্যাল নার্ভ স্টিমুলেশন. Transcutaneous electrical nerve stimulation involves the delivery of an electric current through electrodes applied to the skin surface over the painful region at trigger points or over a peripheral nerve. Acupuncture. Acupuncture is a technique of traditional Chinese medicine in which very thin needles are inserted into the body at designated place. This is the acupuncture. Then heat therapy. Heat therapy, cold therapy also close the gate by activate the inhibitory descending neuron and activates the A beta fibers which stimulate the interneuron and close the action of substance P and close the gate and close the transmission of nociceptive nerve stimulation from the injured tissue to the central nervous system. Cognitive therapy. Cognitive therapy are also behavioral components of pain, include a variety of cognitive strategy, behavioral approaches. For example, patients can identify and challenge negative pain related thoughts, replace them with more positive coping thoughts. Some of these techniques require little training and often adopted independently by the patient, or trained therapist is necessary for the cognitive therapy. Then distraction. Distraction involves redirection of attention away from the pain and onto something else. It is a simple but powerful strategy to relieve pain. Distraction can be achieved by engaging the patient in any activity that can hold his or her attention, that is watching TV, movie, conversation, listening music. This is distraction. Hypnosis. Hypnotherapy is a structured technique that enables a patient to achieve a state of heightened awareness and focused concentration that can be used to alter the patient's pain perception. Hypnosis should be administered and monitored only by special trained clinician. Then relaxation strategy. It also mode of action, it activates the inhibitory descending pathway of the nervous system. So relaxation strategy reduce stress, decrease acute anxiety, distract from pain and alleviate muscle tension, facilitate sleep and enhance the effectiveness of other pain relief measures. This is relaxation strategy. Then comes to this is called WHO analgesic ladder. WHO analgesic ladder was a strategy the World Health Organization proposed in 1986 to provide adequate pain relief for cancer patients. The analgesic ladder was part of the vast health program termed as WHO Cancer Pain and Palliative Care Program. কিসের জন্য এটা করা হয়েছিল? WHO analgesic ladder aimed at improving the strategies for cancer pain management through educational campaigns and the creation of shared strategy and development of global network of support. The original ladder mainly consists of 3 steps. First step, that is number 1, mild pain, যেখানে আমরা নন অপিওয়েড অ্যানালজেসিক দেব such as non-steroidal anti-inflammatory drugs. For mild pain আমরা NSAID দেব or acetaminophen দেব with or without adjuvant therapy. This is the ladder 1. ফার্স্ট ল্যাডারে মাইল্ড পেন থাকলে আমরা নন অপিওয়েড অ্যানালজেসিক দিচ্ছি, যেটা হচ্ছে নন স্টেরয়েডাল অ্যান্টি ইনফ্ল্যামেটরি ড্রাগস অর অ্যাসিটামাইনোফেন with or without adjuvant. Second step, moderate pain, weak opioids, hydrocodone, codeine, tramadol with or without non-opioid analgesic and with or without adjuvant. দিস ইজ ফর মাইল্ড টু মডারেট পেন, যেখানে আমরা উইক ওপিয়েড অ্যানালজেসিক দিচ্ছি, তার সঙ্গে নন ওপিয়েড অ্যানালজেসিক উইথ অর উইদাউট অ্যাডজুভেন্ট। অ্যান্ড দ্য থার্ড স্টেপ, সিভিয়ার অর পারসিস্টেন্ট পেনের জন্য পোটেন্ট ওপিওয়েডস দ্যাট ইজ মরফিন, মেথাডন, ফেন্টানিল, অক্সিকোডন, এগুলো দেবো আমরা উইথ অর উইদাউট নন ওপিয়েড অ্যানালজেসিক অ্যান্ড উইথ অর উইদাউট অ্যাডজুভেন্ট। ফার্স্ট স্টেপে আমরা NSAID দিচ্ছি, সেকেন্ড স্টেপে আমরা হাইড্রোকোডন, কোডিন অর ট্রামাডল, অ্যান্ড থার্ড স্টেপে আমরা মরফিন, মেথাডন অ্যান্ড ফেন্টানিল। And here another one is fourth step. Fourth স্টেপে আমরা ইন্টারভেনশনাল ট্রিটমেন্ট নিচ্ছি উইথ অর উইদাউট নন ওপিয়েড অ্যান্ড উইথ অর উইদাউট অ্যাডজুভেন্ট থেরাপি। এখানে ইন্টারভেনশনাল ট্রিটমেন্টের উপর জোর দেওয়া হয়েছে। তো দিস ইজ দ্য হু ল্যাডার। হু ল্যাডার কেন নেওয়া হয়েছিল? এর ফলে হচ্ছে এর কিছু ভালো দিক ছিল, কিছু খারাপ দিক ছিল। তো এর ফলে যেটা ক্লিনিক্যাল সিগনিফিকেন্স হচ্ছে ওরাল ডোজিং অফ ড্রাগস, যেটা যখনই সম্ভব একটা অ্যারাউন্ড দ্য ক্লকে অ্যাডমিনিস্ট্রেশন করা, অন ডিমান্ডে যে করা হচ্ছিল, সেটার জন্য হচ্ছে তার প্রয়োজনীয়তা এবং ইউজটা যাতে কমে, এবং হচ্ছে যে প্রপার অ্যাডহারেন্স টু দ্য পেন মেডিকেশান এবং প্রপার ডোজ, সেগুলো যাতে ঠিকমতো মেনটেন হয়, সেই জন্য এই ল্যাডারটা, হু ল্যাডারটা নেওয়া হয়েছিল। Then nursing management. A scenario, a 68-year-old male is admitted for hypertension. The patient blood pressure is now under control, but now the patient has developed pain in his left big toe. The patient toe is red and warm to the touch. When the toe is touched, the patient winces in pain. The patient states it hurts to move his toe and that it is painful for a blanket or sheet to touch it. He states it hurt more at night and describes the pain as throbbing and crushing. The doctor's diagnosis is gout. The patient states his mother had gout attacks, but this is the first time he has had one and finds it very painful. The patient rates his pain 8 on 1 to 10 scale. So diagnosis: acute pain related to tissue trauma and reflex muscle spasm secondary to gout, as evidenced by patient rates of pain 8 on 1 to 10 scale and winces in pain. Then subjective data. The patient states it hurts to move his toe and that it is painful for a blanket or sheet to touch it. He states it hurt more at night and describes the pain as throbbing and crushing. The patient states his mother had gout attacks, but this is the first time he has had one and finds it very painful. The patient rates his pain 8 on 1 to 10 scale. And objective data: a 68-year-old male is admitted for hypertension. The patient blood pressure is now under control, but now the patient has developed pain in his left big toe. The patient toe is red and warm to the touch. When the toe is touched, the patient winces in pain. Nursing intervention: the nurse will assess the patient pain level every 2 hours while patient is awake until patient's pain rating is less than 4 on 1 to 10 scale. The nurse will administer colicin 0.5 mg BD per instruction to the patient to help with gout pain and swelling. The nurse will assess the patient's ability to mobilize his left big toe within 48 hours of starting collision. The nurse will educate the patient on 5 signs on how to recognize early signs and symptoms of pending gout attack. Nurse will educate the patient on 6 foods to avoid to help prevent future gout attacks. The nurse will educate the patient on how to correctly take collicin for gout before discharge. The nurse will educate the patient and have him demonstrate 4 non-pharmacological techniques to help decrease pain during gout attack. Nursing outcome: the patient will verbalize decrease in pain by rating pain less than 4 on 1 to 10 scale within 24 hours of receiving pain medication. The patient will be able to move his left big toe without pain in 48 hours after starting collision. The patient will verbalize 6 foods to avoid to help prevent future gout attack. The patient will demonstrate 4 non-pharmacological techniques to help decrease pain during gout attacks. Thank you.